and our Girish Mathur sir and Dr. Minal and all other are welcome to this today's session of thyroid as well as hypogonadism certificate course. And before we proceed further, I think this is the fifth session for the thyroid and fifth for the hypogonadism also. In hypogonadism, we are doing 2 lectures every day. So this will be 9th and 10th lecture today. And before going for the program, I will request Dr. Girish Mathur sir to please say a few words to motivate all the audience as well as the speakers and all of us. Dr. Girish Mathur sir, please.
Thank you, Prakashji. Yes. It's really a pleasure to join the fifth session today of the ICP Certificate Course on hypothyroidism and male hypogonadism. And it's really very heartening to note that we are getting a tremendous feedback from all the participants of these certificate courses. Both the coordinators of the program, Dr. Minal Mohit, Dr. Prakash Keswani, have done an outstanding job. And I congratulate both of them for their very sincere efforts, hard work, and dedication. I also compliment our Dean ICP to take this initiative to start these ambitious programs. I welcome all the delegates, all the participants of today's program, and also the faculty who will be joining later today, Dr. Shivam Priyadarshi and Dr. Deepak Jumani, both leaders in their field who will share their knowledge and experience with us. My best wishes for the success of the program. Let us start it. Over to Dr. Prakash Keswani.
Thank you, sir. Thank you for your nice word. Dr. Minal, shall we start with the thyroid?
Yeah, sir. Sure, sir.
Thank you.
Very good afternoon, everyone present here. And I must thank my seniors for giving me this opportunity. Dr. Alka ma'am has been very kind to provide me this platform. Dr. Prakash Keswani, Dr. Girish Mathur, Dr. KK Parikh sir, Dr. Shyam Sundar, all have been very appreciative and very encouraging all the course through. And all of you specifically who've been very actively participating. I'm sorry for the late posts. My questionnaires come a little late because I was traveling. I was at Pune and I've just come. So I just posted the questionnaire. It's a very simple one. I think you can go through it. It's a very simple set of 10 questions. So we will be discussing today thyrotoxicosis. As I had already told you, the topic for today's was thyrotoxicosis. So we will be talking thyrotoxicosis in adults. We will not be talking of pregnancy. Pregnancy will be the module next week. So as the topic goes, the thyrotoxicosis for today. We'll try to cover the entire thyrotoxicosis in this 1 hour. So when we talk of thyrotoxicosis, as the definition goes, we are talking about all the manifestations that result because of the increased serum levels of the thyroid hormones. So many a times we find that the term hyperthyroidism and thyrotoxicosis are used interchangeably without giving much thought that is there a difference or is there no difference. So technically speaking, when we talk of hyperthyroidism, as the term says, hyperthyroid means the thyroid gland is hyperactive. So whatever the thyroid hormones are in the system, they are because of increased production by the gland. So hyperthyroidism directly or indirectly blames the thyroid gland for the overproduction of the hormones. Whereas when we talk of thyrotoxicosis, we only mean that the serum level of the hormones is raised and the clinical manifestations are just the same that are produced because of the increased serum levels. Now the source of this hormone may or may not be the gland. So the source can be exogenous, that is iatrogenic. The source can be somewhere from the pituitary maybe. The source can be even the ovaries at times. So the source may not be the gland may not be the culprit. So whenever the gland is innocent, but still the serum levels are high, we label it as thyrotoxicosis. Or till we do not know the diagnosis, we label it as thyrotoxicosis. And once we are clear with the diagnosis, then we label the patient as hyperthyroid. So this is basically a very subtle difference. But this subtle difference, if we are clear, that's good for us. So all hyperthyroid patients will be thyrotoxic. So as I told you, till the diagnosis is not clear, we can label them as thyrotoxic. Now, once the patient is thyrotoxic, he or she can be hyperthyroid, or it can be some other cause. So all hyperthyroid patients are thyrotoxic, but all thyrotoxic patients do not necessarily have hyperthyroidism. So when we will be talking to cover this lecture, we will be talking about what are the common symptoms and signs of thyrotoxicosis. What are the causes of thyrotoxicosis, as we are talking that there are other causes other than the gland. How do we approach thyrotoxicosis and how do we reach the diagnosis? How is the clinical feature of each individual etiology different? How do we differentiate among different things? What are the treatment options, and do the treatment options change depending upon the underlying etiology? And what are the etiology specific treatment approaches? So this will be the points to cover, and I think that should actually cover the entire topic. And there are a few things which I will be making sure that Dr. Keswani sir explains better. So the simpler things like what are the symptoms? We are very sure that the patient will come with either complaining of palpitation, nervousness, tremors, fatigability, sweating, heat intolerance. There can be loose motion, weight loss, increased appetite. Women might complain of oligomenorrhea. There can be sometimes atypical symptoms like periodic paralysis, which turns out to be hypokalemic. Then there is generalized itching. Patient might even end up in CCU with atrial fibrillations. There can be apathetic hyperthyroidism in elderly with weight loss, AF, and depression. These are the common symptoms that the patient presents to us with complaints. So when we examine the patient, what we look for, first of all, we look for the gland enlargement, that is goiter, and then we grade it as 1A, 1B, or 2 and 3. Then we look for the eye signs. Are there any thyrotoxic eye signs, that is Graves' ophthalmopathy? Then, of course, we find out the pulse rate. There is existing tachycardia. Is it really a tachycardia or just a psychological issue that is going on? Then we ask the patient for outstretched hands and appreciate the tremors. We clinically examine the warm, moist palms, the muscle weakness, muscle mass loss. Even there is what we talk of as the pretibial myxedema, that is the thickening of the pretibial skin, the nail changes, the skin changes, that is onycholysis, clubbing, and gynecomastia. So these are the various things that we look for when a patient comes to us and we'll think of thyrotoxic patient. Now the thyrotoxic periodic paralysis, as we talk of, is one of the most common cause of hypokalemic periodic paralysis, and mostly it is autoimmune, that is Graves' disease is the underlying cause. What actually happens is that because of the increased serum levels of thyroid hormones, there is intracellular shifting of the potassium because of activation of the sodium potassium ATPase activity. As a result, there is intracellular shifting and the serum potassium level often drops below 3. And whenever the potassium levels drop below 3, the patient starts feeling paralytic. And there is muscle weakness, and that muscle weakness is more in the upper limb as compared to the lower limb. So this is how clinically the patient presents, that is hypokalemic periodic paralysis. And when you work it out, you find that the patient is in thyrotoxic phase, and on autoantibody workup, you find out that it is Graves, underlying causes Graves. The treatment is always a high dose of potassium along with symptomatic beta blockers, and of course the treatment of thyrotoxicosis stands. Then with hyperthyroidism, thyrotoxic patients, there will be sustained overproduction of the hormones by the gland. Whenever there is increased production by the gland, there is a radioactive iodine uptake test that we are doing. We are clinically doing actually 99 technetium uptake. We are not doing iodine uptake because that takes a lot of time. It takes more than 24 hours for the reports to come. So clinically, what we have available in the nuclear medicine is technetium uptake. So what are the causes that the technetium uptake is increased, and what do we mean by increased? We always compare the iodine uptake of the thyroid gland with the salivary glands. So as compared to salivary glands, if you find that the entire iodine has been taken up by the thyroid gland, we call it the increased uptake. And the conditions of increased uptake most commonly is the Graves, but there can be toxic nodules. It can be a single nodule or a toxic adenoma, or it can be multiple nodules called the MNG, the toxic MNG. Even there can be HCG mediated trophoblastic tumors, or it can be a TSH secreting tumors. Then there are conditions of radioiodine decreased uptake. Decreased uptake again because of compared to salivary glands, you will find that the iodine has been taken up by the salivary glands and there is no uptake by the thyroid gland. So the condition is most commonly the thyroiditis. Then the iodine-induced hyperthyroidism again is having a picture of decreased uptake. Then the autoimmune thyroiditis, ectopic thyroid tissue, that is struma ovaroi, or there is functioning metastatic carcinoma, all these will give you a picture of decreased uptake. Now, you will find without hyperthyroidism, again, there will be a decreased uptake, that is thyroiditis. It can be iatrogenic, that is factitious thyrotoxicosis. It can be Hamburger thyrotoxicosis, or it can be amiodarone-induced type 1 thyroiditis. So type 2 amiodarone-induced gives us decreased uptake, and type 1 also gives us decreased uptake. But the picture in type 2, sorry, is of thyrotoxicosis, whereas in type 1 amiodarone that we studied in the last class is having a picture of hypothyroidism. So what are the common causes of thyrotoxicosis? Because there's a huge list which we just discussed, so we will just be touching about the common causes which we encounter almost every other day. So most common cause is Graves, which is giving us a hyperthyroidism and giving us increased uptake. Then toxic MNG, again a cause of increased uptake. Thyroiditis, a case of thyrotoxicosis because of release of the preformed hormones and giving a picture of decreased uptake. Toxic adenoma again will give you a picture of increased uptake because there's a toxic nodule. Then iatrogenic or factitious thyrotoxicosis, again giving you a picture of decreased uptake. So thyroiditis and iatrogenic will be giving you a picture of decreased uptake, whereas Graves, toxic MNG and toxic adenoma will give you a picture of increased uptake. So technetium uptake scan becomes very important to differentiate the cause of the underlying thyrotoxicosis. Now, some of the very rare causes of thyrotoxicosis, but you should know them. Hardly you encounter them clinically. For example, TSH secreting tumors. That is a pituitary tumor, which is producing a large amount of TSH, causing increased thyroid hormone secretion by the gland. Then there are H-mole choriocarcinomas. There can be Jod-based disease, struma ovaroi, amiodarone-induced thyroiditis, or it can be a metastatic follicular thyroid cancers. So all these are very rare causes of thyrotoxicosis, but you should keep them in mind. So coming to Graves' disease, which is the commonest cause. Graves' disease, also known as the von Basdorf disease. Now, Graves, as we all know, is an autoimmune disease. Autoimmune disease, so there are autoantibodies. Now, these autoantibodies are actually the thyroid stimulating hormone antibody, receptor antibodies. So TSH receptor antibodies. They are also known as a thyroid stimulating immunoglobulins or thyroid stimulating TRAB, that is TRAB, that we commonly call them TSH receptor antibodies. This Graves is commonly associated with the HLA-DR3 population. There is defect of suppressor T cells. Now these B cells, they are the immunoglobulin synthesizing cells, and they synthesize thyroid stimulating immunoglobulins, that is TSI. Now these antibodies, they stimulate the gland just like the TSH. They go and bind to the receptor and they cause autonomous stimulation. That also lead to infiltrative orbitopathy. So there are eye signs because of these infiltration of the eye muscles. And there is infiltrative dermopathy, which is the pretibial myxedema that we call as, or we also find changes in the nail bed, that is onycholysis. So this is about Graves, how it happens and how it manifests. Antibodies against TPO, thyroglobulin, or the TSH receptor, all these antibodies may be present. There is lymphocytic infiltration on, when you go for FNAC, you will find a lymphocytic infiltration. There is no follicular destruction you will find, there is only lymphocytic infiltration. Now this antibody formation is from the thyroid lymphocyte infiltrate as well as extrathyroidal. Extrathyroidal we already know. The antibodies cause infiltration of the eye muscles as well as the infiltration of the skin. So human TSH receptor, the basic antigen is the TSH receptor. The antibodies are formed against the TSH receptor. So TSH receptor antibodies are formed. Now these TSH receptor antibodies are of three types. It can be stimulatory, it can be inhibitory, or they can be inactive. Now, Graves' disease is actually caused by stimulatory antibodies. So, TSH receptor stimulating antibodies, also known as TSI, that is stimulating immunoglobulins. Now, as we were talking of the antibody, the receptor antibodies, they can be various types. They were called earlier by various names like the LATS, TSI or TBI in receptor assays. The TRAB antibodies, they can be stimulating, they can be blocking, or they can be neutral. Graves only result when there is TSAB, that is thyroid stimulating antibodies. Whenever there is presence of thyroid receptor blocking antibodies, which is a very rare condition, but this condition results into hypothyroidism. If there is formation of neutral antibodies, they are ineffective and are non-functional. They do not cause any clinically significant value. But because of the theoretical knowledge, when we talk of the TSH receptor antibodies, there are of 3 varieties. Most commonly, 85% it is stimulating antibodies, and that are responsible for Graves' disease. So both stimulatory and blocking antibodies are present, but these are the stimulatory antibodies which are clinically significant. Now these receptors, they have an extracellular portion called the leucine-rich domain. Now the TSH and the antibodies both go and bind to these leucine-rich domain. So if these antibodies are bound there, they cause autonomous stimulation of the gland. Receptors can only detect the presence of antibodies. Whenever we talk of bioassays, when you go for clinical bioassay, they will only measure the stimulating antibodies. So they will not detect these antibodies, but theoretically, there are some blocking antibodies also present. So this antibody, another important point to differentiate, we studied in hypothyroidism that TPO antibodies and the TG antibody, thyroglobulin antibodies are present in the normal population also. But the TSH receptor antibodies, they are not present in the general population. So if the receptor antibodies are detected, that means that the patient is already having underlying proposition towards Graves' disease. So these are the stimulatory antibodies. They go and stimulate the receptors. These are the blocking antibodies. They just block the receptors and they lead to hypothyroidism. But these are the antibodies which are not detectable in the serum. Our labs are not detecting them. Our labs are only detecting the stimulating antibodies. Then these are the neutral antibodies. They just go and stay at the side of the receptors and they just don't interfere with the working of the TSH. So this is the 3 types of Graves antibody, and the other 3 types of TSH receptor antibodies. So this is one very, very theoretical part, the spontaneous hypothyroidism in Graves. That is because of the blocking antibodies at times, and we just don't even know, we are not even able to appreciate it because these antibodies are not detected and the patient presents to us as hypothyroidism, and there is actually the presence of thyroid receptor antibodies and they are not detected by our labs. So we will be talking of the stimulating antibody, that's a Graves' disease, a clinical behavior. You will find that this is whenever there is high titers of the stimulating antibodies, the patient lands up with hyperthyroidism. Then there is toxic MNG. What happens in toxic MNG? We know that the gland structure is follicular. So this basic follicular structure of the gland is not destroyed, not damaged, but there is long-standing multinodular pattern. So these nodules, they start generating and they start increasing in size and then they become functional. On clinical examination or palpation, you will find that the gland is multinodular. There are nodular pattern of the gland. On RAI, again, you will find that there are multiple toxic nodules in the gland which have a patchy distribution. And hyperthyroidism in patients become just like excess iodine is intake, like there is already existing multinodular goiter, but the patient is euthyroid. But this patient is when exposed to high doses of iodine, then suddenly you will find that the patient goes into a Jod-based phenomenon and the patient becomes toxic. So it's a cause of toxic multinodular goiter. So again, how do we reach here? As I told you, the gland itself has a follicular structure or a nodular structure. So the final phase of evolution, by the time, over a period of time, these nodules, they keep on growing slowly by the period of time, and then they gain autonomy. At times are influenced by external factors. They may be influenced by growth factors, goitrogens, iodine. There may be hereditary or genetic factors, and all these culminate into toxic MNG. There are monoclonal expansions of the follicles, and all these monoclonal expansion leads to follicular enlargements. Sometimes there are certain mutations also which are responsible that ultimately cause toxic MNG. Just have a pictorial look here. The patient is in euthyroid phase. The thyroid hormones are normal. And this is a normal gland and there is just one nodule which is not even clinically appreciated. And you will find that eventually there are more nodule formation and these nodules eventually start rising in number, but the patient is still in the euthyroid phase. And over the period of time, these nodules, they become autonomous. There is increased hormone synthesis and there is suppression of the TSH. The TSH was normal. It goes on decreasing. And finally, the TSH is very, very low. The thyroid hormones are rising. This is a normal thyroid hormone. This is coming from the toxic nodule. Initially, it was very less, but eventually you will find that the toxic nodule is producing so much of hormone that there is TSH suppression. And as a result, the normal thyroid gland is not producing any hormone. So whatever hormone is coming, that is coming from these toxic nodules. So that is how toxic MNG evolves. So clinical features, you will find a large asymmetric nodular gland. There will no other sign of Graves, like the Graves of ophthalmopathy or the Graves dermopathy. They will not be there. Typical picture of thyrotoxicosis, picture of tremors, palpitation, sweating, weight loss, all those will be there. But the extrathyroidal manifestations of eye signs or skin manifestations will not be there. On technetium uptake, there will be increased uptake. So this increased uptake will not be a diffuse glandular uptake, but it will be a diffuse patchy uptake. And on sonography, you will find multiple nodules with hypervascularity. So clinically, you will find that the TSH is suppressed and the hormones are raised. Now this hyperthyroidism is of course clinical and the gland is large. There's a huge goiter, multinodular. So there can also be pressure symptoms or compressive symptoms. This is about the MNG. What about a toxic nodule or the plumber's disease, as we call it, a toxic adenoma, which is also known as the plumber's disease. In the toxic adenoma, there is a single nodule. There's a monoclonal expansion of one single follicle or a single nodule, which grows eventually. It escapes the suppression effect of TSH or the stimulation effect of TSH and becomes autonomous. As a result, it becomes a toxic adenoma. And the remaining gland, it goes into a suppressed phase. So they are never malignant. Toxic nodules are never malignant. They are mostly always benign. Any nodule which is above 2.5 centimeter, we always suspect that it can be a toxic nodule. Again, on a technetium uptake, you will find there is a focused high uptake mass. And that high uptake lump or mass is your toxic nodule. Treatment, mostly when we talk of these toxic adenomas or toxic nodules, we prefer either surgery or radioablation. This is very interesting that very rarely you will come across a normal T4 and still you will find a low TSH. So these are the cases of T3 toxicosis. So mostly the T3 toxic cases are toxic adenomas because these isolated islands or isolated nodules, they actually start producing the T3. Then what about thyroiditis? Though we touched thyroiditis in our last class also, thyroiditis, they can have autoimmune origin as Hashimoto's thyroiditis, or they can have viral origin, or they can have trauma, or they can have many other reasons also, even bacterial at times. But on technetium uptake, you will find that these are the gland will give you a picture of empty gland. Whatever hormone was preformed is released into the system and the gland is now empty. So there is no uptake on the 99 technetium uptake scan. In the toxic phase, the patient will have clinical picture of thyrotoxicosis. You might require a symptomatic treatment with beta blockers. If it is a painful thyroiditis, you can treat it with steroids or NSAIDs. Autoimmune etiology, yes, if it is Hashimoto's, it can lead to hypothyroidism. If it is non-autoimmune, then you can be hopeful that once the thyrotoxic phase is over, patient might become euthyroid. Treatment, once the patient has landed in hypo phase, we do not treat the hyper phase, but when the patient has landed with a hypo phase, we start thyroxine replacement. So this is about thyrotoxicosis due to thyroiditis. Now, this is the clinical pictures. Now, how do we approach thyrotoxicosis? How do we differentiate the various types that we have seen, but how do we approach them clinically? So clinically, you will find that there is a patient in your chamber with clinical symptoms and signs of thyrotoxicosis. A lab report he is carrying, which is showing a very low TSH suppressed, that is 0.01 or less than 0.0, and T3, T4 both are on the higher side, or maybe they are borderline marginally raised. It can be subclinical hyper or it can be overt hyper. So now you have the challenge in front of you is whether it is thyrotoxic or whether it is hyperthyroid. So you have to first differentiate whether we are dealing with thyrotoxicosis or is it a case of hyperthyroidism. So to differentiate, we go for either a scan, that is a technetium scan. We think of thyrotoxicosis depending upon what are the clinical pointers, clinical markers, because last time also we discussed that some of us are practicing in areas where most of the high advanced lab facilities of the nuclear medicine is not available. In such cases, what are the clinical pointers? So clinical pointers are something like, what is the duration of the disease? If the duration of illness is short, then you are dealing with thyrotoxicosis probably. What is the severity? If it is very severe, then you are dealing with hyperthyroidism. What about the goiter? Is there a presence of goiter? Then again, you are dealing with hyperthyroidism. Are there signs of eye involvement or skin involvement? Then again, you are dealing with hyperthyroidism. So to confirm, you find out the ratio of T3, T4. If the T3, T4 ratio is very high, for example, say more than 20, then again, that is in favor of hyperthyroidism. You go for scans if they are available, that is 99 technetium scan, or you go for sonography and Doppler. If there is marker of increased vascularity, you are talking of hyperthyroidism. If there is a marker of atrophic thyroid, then you are probably dealing with thyrotoxicosis. Antibody levels, if the labs are giving you the reports of TPO antibodies, then you are probably dealing with thyrotoxicosis. If you have the presence of TRAB antibodies, then goes without saying that we are dealing with hyperthyroidism. So once this is how you approach the patient, and once you have all this with you and you have reached a diagnosis, then we approach the patient for treatment. Whenever there is goiter present, we think of hyperthyroidism, and when we talk of hyperthyroidism, we discuss either it is Graves or it is toxic MNG or it can be toxic adenoma. So in Graves, the goiter will be diffusely enlarged. It will be soft to firm, non-nodular. You can appreciate a bruit at times or a thrill. It will be mobile with tongue protrusion and with swallowing. Mostly it will be non-tender and there will be no associated lymphadenopathy. So that is a typical goiter of Graves. In toxic MNG, the goiter will be again nodular on palpation. You can appreciate more than 3 nodules differently in both the lobes maybe. The patient will give you a history of very long duration that initially I was perfectly fine, but these nodules were always there. But now they are troubling me because now the nodules have become autonomous. They might even extend substernally. And as we studied in the last class, something called Pemberton sign, that is, you ask the patient to raise both the hands and hold them above the head for 30 seconds, and the face turns blue because of the subclavian syndrome or the compression of the subclavian vessels. So this Pemberton sign is positive because of substernal extension of the gland. It's a large, huge gland which is multinodular and which is long-standing, but now it has become autonomous. When we talk of goiter of thyroiditis, again it will be diffuse, nodular, but it will not be soft. It will be a firm nodule. It will still be mobile. It can be tender or non-tender depending upon the underlying thyroiditis etiology. But the important pointer is that thyroiditis mostly will be associated with lymphadenopathy. Even if it is Hashimoto's, it will be lymphocytic infiltration of the lymph nodes as well. If it is infective, then definitely there will be associated lymphadenopathy. And there is no bruit. So this is about how do we differentiate about the goiter of Graves, toxic MNG, and the toxic adenoma. So Graves will have many symptoms, longer duration, goiter, proptosis. Even patient might give you a positive family history. Toxic MNG, again, long-standing asymptomatic, now becoming symptomatic. Large multinodular goiter with no eye signs, no skin signs. Toxic adenoma, again, it can be of variable duration. Symptoms will be of different intensity, single nodule with no sign, eye signs or no skin signs. In case of thyroiditis, a very short history, thyrotoxic picture merging into euthyroid or hypothyroid, incidentally coming to your notice. The entire spectrum is over in 6 weeks. And then there are associated fever, no family history present, no eye signs, no skin signs. So, and a history of a recent viral exanthema. So all this will be a pointer towards thyroiditis. Iatrogenic, of course, the patient is giving you a history of hypo and now becoming hyper because of over intake of medication. Maybe the drug is being abused for weight loss. Then there will be associated tachycardia, proptosis will not be there, goiter will not be there. And patient will give you a very dicey, very confusing history. And the patient is switching between hypo, hyper. So that gives you a pointer towards that something is wrong here. So this is about clinical differentiation. Now, what about the lab differentiation? Lab workup, you ask for, first of all, you always ask for a thyroid profile. So TSH, T3, T4, and you might even require FT4. You can calculate, or you can just look at the T3, T4 ratio. Antibodies, the TPO and the TRAB antibodies. Sonography, you can ask for. Then uptakes, if it is a hyper picture, because we are talking thyrotoxicosis, we need a technetium uptake scan. That is a thyroid scan. And then, of course, there are specific, if you are thinking of some specific etiology, like struma overi, you can ask for a sonography of the pelvis. So these are the specific tests that you need to have with you before you reach a diagnosis. So the TRAB antibodies, though we have discussed already, but the utility of TRAB is more in the negativity. So if they are absent, you are definitely not dealing with Graves. But if they are present, they are a very important marker of Graves. And when you are planning to stop the treatment of Graves, that is at the end of 2 years, again you can repeat the TRAB, and they're also a predictor of relapse of the Graves disease. So if the patient is having a very high level of TRAB, though the patient is euthyroid because of on medicines, do not consider withdrawal because this patient will end up into a relapse. So as per the 2016 guidelines of American Thyroid Association, TRAB is used for the differential diagnosis of the etiology of thyrotoxicosis if RA, that is radioiodine uptake, is not available. So TRAB measurement has to be done every 1 to 2 years after the anti-thyroid drug treatment so that we can predict the relapse. So that is the significance of TRAB. Even during pregnancy, you can ask for TRAB. Then even for your orbitopathy or ophthalmopathy, you can ask for TRAB. Postpartum thyrotoxicosis, you can differentiate with the help of TRAB. Thyrotoxicosis in the neonates who are born to the mother with Graves. So the fetal Graves or the neonatal Graves can be detected by the help of TRAB. So the TRAB antibodies have a lot of significance, and we should probably, if available, we should ask for the TRAB values. Now, some of the unusual thyroid function tests in case of thyrotoxicosis. Suppose there is T3 toxicosis. In case of T3 toxicosis, mostly you will come across toxic adenomas will have T3 toxic picture. So you will have a high T3 with a normal T4 and a low TSH. Now, this is again a very rare case, but whenever you find a normal T4 with a suppressed TSH, do not always jump to think of secondary hypothyroidism. And clinically, if the patient is toxic, if the patient is thyrotoxic clinically, always find out T3 toxicosis. It can be toxic adenoma or it can be Graves in iodine deficient areas. T4 toxicosis is a very simple picture, which is a very usual picture that high T4 and TSH is suppressed. Now, biochemically in thyrotoxicosis, the TSH is secreting pituitary tumor, all are raised. You will find biochemically patient coming to you with high T3, high T4, high TSH. Now, this is a picture where you will think of TSH secreting tumor. Again, a very, very rare incidence. TSH secreting tumors are very rare. If the patient is not toxic, again, I'm just emphasizing, if the patient is clinically not toxic and there is raised TSH, raised T3, raised T4, think of resistant thyroid hormones that we already have studied in our previous classes. What is resistance to thyroid hormones at the pituitary level as well as at the peripheral level? But if the patient is clinically thyrotoxic and all the three are raised, then we think of TSH secreting tumors. So the resistance syndrome is also very well known to all of us. The patient will be euthyroid clinically and there will be raised TSH and raised T3, T4. And it is because of the mutation in the beta receptor gene, beta arm of the thyroid TSH receptor, where there is T3 binding. And this is another pointer that whenever we are dealing with any syndrome, mostly there will be other family member, there will be a hierarchy, and you can draw a genetic tree out of this. So just for our understanding, suppose we have a 46-year-old male, DK. He has a history of weight loss of 11 kgs, polyuria, 3 months, no other complaints, both parents diabetic. Obviously, looking at this, you will say this is a case of type 2 diabetes, because loss of weight is also common with new onset diabetes, which is very high. And if the patient is having both parents diabetic, he may be diabetic also, because he's also giving a history of polyuria. So on workup, you find out that his fasting is high, PP is high, HbA1c is also high. His FT4 is also high and TSH is low and the TPO is negative. So we are dealing with a case of thyrotoxicosis with type 2 diabetes. So on clinical examination, there is no goiter, but there is tachycardia and there is no other abnormality. Diagnosis, we already have diagnosed this as thyrotoxicosis with type 2 diabetes. So you ask this patient to go for a 99 technetium uptake scan, and on the scan, this is the picture. There are no salivary glands visible because the entire technetium has been taken up by the thyroid glands, and both the glands are enlarged and there is homogeneous uptake in both the glands. So we are dealing with Graves' disease. So there is mild to moderate enlargement of both the lobes, isthmus and pyramidal lobe, which is visualized. You can see this pyramidal lobe visualized. Increased tracer concentrations and homogeneous distribution with no apparent focal defect. So there are no cold nodules, no hot nodules. There is both lobes, including the isthmus and the third, that is the pyramidal lobe, which is visible here. So it's a case of Graves' disease. Now, what about this patient? 32 years old female, coming to you with history of weight loss 3 kgs. Now 3 kgs is not much in 1 month with no other complaints. Normal blood glucose, normal X-ray, thyroid function reveals T4, FT4 2.8, which is raised. TSH is undetectable, which is again very significant. On clinical examination, goiter of grade 1B with non-tender and pulse 104 with no other abnormality. So what do you diagnose? Maybe this is a short history, just history of 1 month, no other complaints, and the rise in FT4 is also not significant. It is definitely high, but not very high. Goiter is again not very large, it's just 1B goiter. 1B goiter is one which is visible to us without, what do you say, without the neck extension. If you can appreciate the goiter, that is 1B goiter. So you ask for a scan, and the patient comes to you that all the salivary glands, the parotid, the sublinguals, the submaxillary, they are all visible glands. The salivary glands are visible, but the thyroid gland is not visible. There has been no uptake in the thyroid gland. So we are dealing with a case of thyroiditis. Now let us see a 53-year-old female, history of neck swelling left side since 3 months. There's a small nodule here, no family history, weight loss present, no signs of thyrotoxicosis. FT4 is marginally raised, TSH is suppressed, antibody is normal. TPO antibody is normal, but there is a nodule here, a small nodule with increased uptake maybe. So we are dealing with probably a case of toxic adenoma. So we have a thyrotoxic patient, thyroid nodule and TPO negative. So you go for a sonography, and sonography gives you a nodule with cystic areas in the left lobe. Sonography again giving you a nodule area. This is a cystic nodule present here. A scan gives you a very clear picture that the entire gland here is enlarged, but within the gland you cannot appreciate here. This picture is not giving a very clinical picture, clear picture. But if you can appreciate that there is a leftward deviation and there is enlargement on the left side. So the nuclear scan is giving us autonomous toxic nodule in the left lobe, which was clinically palpable and also sonographically appreciated. So these are the differentiating pictures. These are the three types of patients coming to us. Either it is a Graves or it is toxic MNG or a toxic nodule. Clinically, these are all hyperthyroid. And this hyperthyroid we differentiate based on based on technetium scan. And once we have appreciated and diagnosed the patient, how do we treat them? So first of all, we all know that the first line of management is always a beta blocker. So we always try to block the clinical effect of the hormone which is already in the system. So we try to block or break the pathway of the existing hormones in the system. Then we try to decrease the thyroid hormone production. So to decrease the production, we use anti-thyroid drugs, or we use radioablation, or we can even do a surgery. So which approach for which patient, which method will be applicable to which patient, that will be etiology specific. And also we have further specialization because of etiology specific treatment. Whenever we are treating without the specific drugs, we are just treating symptomatically, we call it adjuvant therapies. And adjuvant therapies most commonly are beta blockers. If beta blockers are contraindicated because of some reason, you can use a calcium channel blocker. For example, in heart failure, the patient, you cannot give a beta blocker. You cannot give a dexamethasone, you cannot give a calcium channel blocker. So you can use digoxin. So you are giving adjuvant therapies. They can be beta blockers to control the heart rate. They can be calcium channel blockers like diltiazem or verapamil. They can even be steroids to control the symptoms. Mostly we are using the iodine. You can use iodine SS, that is super saturated solution of potassium iodide, which contains 50 milligrams of iodide every drop. Is the 3 to 4 drops are administered every 8 hourly. Or you can use a Libol solution, though these are very difficult available. These iodine preparations are not available in the market. Very difficult, you can get them. I'm not saying you don't get them, but it's a challenge. Then of course, lithium available. Lithium can be used to further inhibit the release of hormones from the gland. These are all adjuvant therapies. The specific therapy is only the anti-thyroid drug, that is thionamides. So all the anti-thyroid drugs so far we have are thionamides. Thionamides are the class of drugs which are further divided into either propyl thiouracils or the carbimazole. Thiouracil group and the carbimazole group. When we talk of thiouracil group, we have propyl thiouracil with us. When we talk of carbimazole group, we have neomercazole and we have methimazole. We have carbimazole and methimazole. So carbimazole, methimazole are one class, that is the carbimazoles, and this is the thiouracils. Conversion formula is very simple. It is 1:10 for carbimazole and PTU. So if you are using 60 milligrams of neomercazole, you will be converting to 600 milligrams of PTU. So it is 10 times. If you are using methimazole, then you bring down the dose by 3/4. Sorry. Something. So we have the anti-thyroid drugs. This is the mechanism of action. So out of these drugs, we know that propyl thiouracil is the molecule which will also inhibit the peripheral conversion, whereas carbimazole group will only act at the gland level and will stop the synthesis of the hormones. So this is how they work. So these anti-thyroid glands, the anti-thyroid drugs, they go and get concentrated inside the thyroid gland, and they interfere with the iodinization of the thyroglobulin. Now this we'll have to remember right from our class 1, when we started studying that how are the thyroid hormones synthesized. So we know that there is tyrosinization of the thyroglobulin, and there is monoiodotyrosine, and there is diiodotyrosine. And when monoiodo and diiodo, they get together to form T3, and 2 molecules of diiodo, they get together to form T4. So So this is iodinization of thyroglobulin is interfered because of anti-thyroid drugs. And they also serve as alternative substrate for oxidized iodide to bind, and they compete with thyroglobulin linked tyrosine residue. Sulfur-linked iodide is formed as a reaction product, and they just, one thing we have to explain to the patient that the goiter size will not change. There might be a small shrinkage, a small atrophy, because whichever is the hyperactive form of the gland, there might be a slight clinical atrophy, but appreciably the size of the gland will not change by our treatment. It is only the clinical improvement that will happen. Then there are these anti-thyroid drugs have some other effects also. There are immunosuppressive effects, and propylthiouracil also blocks the peripheral conversion by blocking the D1. So when we compare PTU versus methimazole or carbimazole, we find that methimazole, carbimazole are the longer acting with a T-half of 6 hours, and they can be given once a day. Whereas PTU has a short half-life of 1 hour and it is given 8 hourly. Mostly it is given 8 hourly. The preparation of PTU is available as 50 milligrams, and we are giving it to the maximum dose of 600 milligrams. Similarly, the carbimazole maximum dose we are giving is 60 milligrams. Now, this is important to remember that PTU is also protective against radioiodine. So whenever you are planning a radio ablation, you have to stop PTU for at least 15 days. Whereas if the patient is on carbimazole, you can just withdraw the drug for 7 days. So as per the latest recommendations, PTU has been found to cause serious liver injuries. So it is not widely recommended unless really required. Mostly we prefer using the carbimazole group, because carbimazole group does not have the liver effect, the liver damaging effect. But the common complication or side effect of carbimazole is agranulocytosis. Now this is again a group effect. It is not only carbimazole. If it is happening, it will happen with PTU also. So it's a group effect. So there is agranulocytosis, thrombocytopenia, DIC, hepatitis, vasculitis, nephrotic syndrome, SLE-like syndrome. There can even be rashes, urticarias, arthralgias. There can be increased liver enzymes, fever, and lymphadenopathy. But these are minor features, that's okay. But if there is agranulocytosis, then you need to withdraw the drugs and counsel the patient only for ablation, that is radioablation. So agranulocytosis, basically it is an idiosyncratic reaction. It might happen suddenly. It might happen with the first dose, or it might happen after a few months. Averagely, it happens within 30 days. It can occur in any patient. It can occur in a patient who has already received the drug earlier. It's an autoimmune condition again. So anti-granulocyte antibodies are formed. A WBC count or an absolute granulocyte count is required, and if the total count drops below 1000 or 1500, we must immediately withdraw the drug and start the patient on, plan the patient for radioablation. Meanwhile, treat the patient symptomatically. So radioiodine therapy, it is again not a therapy without its own set of evils. It has its own challenges. What we are using clinically is iodine 131. We are using beta radiations to the tune of around 10 millicurie. 10 to 12 millicurie is given, when 1 millicurie we know is 37 millibecquerel. So the dose has to be fixed, or it is calculated depending upon the size of the gland and the uptake of the gland. If the uptake is very, very high, then you can give a slightly on the higher side. If the uptake is low, then you can use a normal dosing, that is around 10 millicurie. Higher doses are required in MNG. They are safe radiations and they do not cause any damage to the body. Initially, we were not using it for children, but now they have been considered safe even in the pediatric population, and radioablation is being used in children even up to the age of 10 years, anytime after 10 years, though we are using it even in younger children. We need to stop the antithyroid drugs. If the patient is on PTU, then 14 days. If the patient is on carbimazole, then 7 days prior. Once this therapy is given, after 7 to 10 days or even 15 days, you can restart the therapy. You have to restart the antithyroid drugs, and then you have to slowly taper them down within a period of 1 year. Within a period of 1 month. So within 1 month, you withdraw the antithyroid drugs. If the patient is a woman and planning a pregnancy, then this pregnancy needs to be postponed at least by 1 year. Then besides this, there are certain few more recommendations. You calculate the dose, antithyroid drugs to be restarted after 7 to 15 days. And if the patient is on PTU, then of course you have to withdraw it before 14 days and the dose has to be a little higher. Radioiodine therapy can also cause side effects. There can be there will be hypo rather. There can be even radiation thyroiditis. There can be an enlargement initially of the thyroid gland. There can be inflammation of the salivary glands. There can be CL adenitis. The ophthalmopathy might worsen because of the radiation or because of the radioiodine. It is considered safe, but there are very rarely reported cases of cancers, and even it is unsafe for the pregnancy and mothers planning a pregnancy because they are teratogenic. So worsening of ophthalmopathy is a very common side effect that we have seen with radioiodine ablation. And if the patient is having eye signs, then we do not use radioiodine ablation. We prefer keeping the patient as antithyroid drugs. Patient will become hypothyroid. Radiation thyroiditis, if happens, will last for another 10 to 14 days. Very rarely, the patient might also become hypopara. Now, cancer, the incidence of cancer has not been reported either in UK, Swedish or US studies. But besides this, still we have that fear, and most of the patients have that fear that this radiation might land them up with cancers 10 years down the line, 20 years down the line, and they might become the harbinger of some cancers. So how do we give this patient a certain instructions? Very importantly, if there is a small child in the family, then these radioiodine ablation is not recommended. Maximally 15 days precaution, mostly to generalize, though this theory says 2 to 3 days of precautions, but practically we are using a 15 days guideline. Patient is supposed to be isolated, quarantined, something like we faced in Corona. Patient needs to be quarantined, sleep in a separate room, do not go to work, do not mix with people, do not get into public parties, public places. You have to have your own separate room. You need to have your own separate washrooms. Do not cook for the family. Use disposable utensils. Discard your clothes for those 15 days. So these are general precautions that you are following. Do not travel much and take a lot of fluids and keep yourself hydrated, busy, and productively engaged. Surgery, mostly we are not recommending surgeries, but yes, if there's a very large gland, then we are recommending a near total thyroidectomy. Very large glands with ophthalmopathy or with compression signs, then surgery is recommended. But before we take up surgery, patient needs to be euthyroid. And to make the patient euthyroid, we can use any of the methods. And if the patient is very severely hyperthyroid, then you can use even iodine. Etiology specific approaches, I think we have already touched. Graves, we will be using either a medical management with antithyroid drugs, or you can even use a radioiodine ablation. Toxic MNG, preferably we use ablation or surgery. Adenomas, we preferably again use ablation or surgery. So medical management will not work in case of toxic MNGs and toxic adenomas. They will only make the patient euthyroid, but if the moment you withdraw the drugs, there will be a recurrence. So in Graves' disease, stimulation by TSH-like antibodies, MNGs are autonomous, adenomas are autonomous. Thyroiditis will depend upon the preformed hormone release. Gestational thyrotoxicosis, here it is because of HC gene stimulation. Thyroid trough adenoma is a pituitary adenoma TSH secreting tumors. Graves' basic pathogenetic factors are still not treatable. By nature, whenever there is abnormal stimulator is withdrawn, disease will go into remission. Therapies are palliative. We always try to keep the patient in remission. Relapses may still occur with all our precautions. We prefer going for ablation in US, but in UK, they prefer antithyroid drugs. And in India, it is always the decision of the patient. If the patient is not very happy with, because it's a cost-effective therapy. It is not very costly. The cost of this radioiodine capsule, this radioablative capsule is 10 to 12,000 in Jaipur. I'm not sure of the other centers, but in Jaipur it is costing 10 to 12,000. And most of our government patients, the ECHS, CGHS are even getting it complimentary from centers like Bhagwan Mahavir and centers like there are, I think Bhagwan Mahavir is one place which is giving free of cost. So medical management, we can treat them by titration regime or we can treat them by block and replacement. Block and replacement is an obsolete regime and we are not using it nowadays. We are only using the titration regime. And when we use a titration regime, we are using a down titration, that is hit hard and hit early. We give the maximal tolerated doses, that is 60 milligrams of neomercazole or 600 milligrams of PTU. Though we are not using PTU, mostly we are using neomercazole or methimazole. And then we down titrate depending upon the reports. When to stop the drug? Please do not treat them for life. So stop the medicines after 18 to 24 months. There will be 50 to 60% chances of relapse. Relapse will be higher in the postpartum periods. You need to follow up the patients for quite long, maybe lifelong, and they might become hypo. They should become hypo and keep them in hypo. And then you can treat them with thyroxine replacement and make them euthyroid. So what are the predictors of relapse? Which patient will come back? If the goiter is large, if the initial thyroid hormone is very high, if the TSH is very low, if the uptake is very high, if the antibody levels are very high. So very genuine predictors. So 50% will stay in remission, 50% will relapse, 30 to 40% will stay in euthyroid remission, some 15% will become hypothyroid. Ophthalmopathy is an independent status. Patient may be hyper, hypo or U. Patient might continue to have Graves' ophthalmopathy. And the eye signs of thyrotoxicosis we will discuss in some other class. Whenever there's a relapse, you redo a ablation or you consider surgery. Medical management for a relapse is usually not recommended. So radioiodine, this is a preferred treatment, but we are avoiding in elderly patients with ischemic heart disease, severe thyrotoxicosis. Again, there will be a storm. If the gland is very large, more than 100 grams, please plan a surgery. Achieve euthyroid status first, and then you may undergo a surgery. And if the woman has undergone a radioablation, then the pregnancy should be avoided for at least 1 year. Whenever we plan a surgery, we go for a subtotal thyroidectomy and we just leave a 2-gram tissue behind. This 2-gram thyroid gland tissue is sufficient to maintain a euthyroid status. Preoperatively, we keep the patient on symptomatic beta blockers, or patient might require even a supersaturated solution of potassium iodide. In toxic MNG, again, we require a ablation or a surgery, but before that, make the patient euthyroid. Radioiodine, we need a higher doses. So stop the medical management 7 days prior, or if it is PTU, then 14 days prior, and then go for radioablation. If symptomatic, you may continue the antithyroid drugs. Once the patient has achieved a euthyroid status, then you plan a radioiodine ablation. Now, this is one question, this point which is very confusing, that you might even treat the patient with thyroxine for up to 2 weeks prior to radioablation. I'm not sure why we are doing this, but this is theory which says this. I have not practiced this clinically. Maybe Dr. Keswani can explain this to me as well, that why the theory is recommending that we might recommend a thyroxine for 2 weeks before making the patient undergo ablation. Other than that, most of the things are very, very normal and very routine things that we are practicing every day. In thyroiditis, we only treat with beta blockers, NSAIDs. If very severe, you might require steroids. Avoid antithyroid drugs, wait for a period of 6 weeks, and the patient will become euthyroid or end up with hypothyroidism. Then there is something called subclinical thyrotoxicosis. Again, a picture like subclinical hypothyroid, that the TSH is suppressed, but T3, T4 is normal. But we treat similarly, approach similarly, because the damage is just the same, that the thyrotoxic patients will have osteopenia, osteoporosis, there will be cardiac risk, there will be atrial fibrillation and cardiovascular mortality. So the treatment remains just the same. Surgery, we have already discussed, we are rarely recommending, but if we are recommending, first we make the patient euthyroid and then we go for subtotal thyroidectomy. I think that is all. There's a lot of time. There's thyroid storm. Yes, again, there's a thyroid storm and patient will be in AF. So we need a team approach. The cardiologist must control the AF first, and we should control all the symptoms. We must be using multiple approaches. We must be using the PTU because of the inhibition of the peripheral conversion. We also use lithium to stop the further release of the hormones. And of course, the symptomatic beta blockers or the adjuvant therapies are utilized. This is a scale. How do we calculate the thyroid storm scoring? This was very old scale. Nowadays, we are not actually using it clinically, but these are more for the research and the paperwork or the paper studies. Management is, again, as we discussed, antithyroid drugs, establish euthyroid status as early as possible, and then you go for a surgery if the gland is very, very large, because if it's a storm, the gland is supposed to be very large. AF is managed by the cardiologist. I'm not going into it. I think that is all. My time is also over. So thank you very much, sir. You can take up a few questions.
Thank you, Dr. Minal. You have spoke very well and explained all the aspects of the hyperthyroidism, including etiopathogenesis, clinical presentation, treatment, radioactive iodine therapy. It was very informative and quite clear. And Madam Alka Deshpande was also hearing it, and Dr. Jumani, you can see that he's appreciating. We have it on the phone. He was also appreciating how Minal speaks well. And compliment to you.
Always.
Yes.
Thank you, sir.
Dr. Minal,
yes.
I must congratulate you and also your participant, because you are really taking pains, making all the efforts to give a very comprehensive knowledge about thyroid dysfunctions. I'm very, very happy.
Thank you.
That is very evident from the questions that you are getting, because people are discussing their difficult cases and some, dilemmatic problems amongst themselves as well as to you. So that is the success of our short course. And I'm very, very happy. Must congratulate you and also the participants.
Thank you, ma'am. Thank you so much.
It's really good. And I think there is a demand again now to start the same thing in September. Of course, if you agree and if you are not tired. And I don't think you are tired, because teaching gives a pleasure, I take it as that.
Absolutely, ma'am. Absolutely.
Yeah. So you have to work for your pleasure, not for any other thing.
I do it.
Let us see how it goes. And Dr. Keswani is also doing wonderful. Male hypogonadism initially was thought that people may not be interested, but there are so many questions. And along with Dr. Keswani, I must thank all the experts that he has invited, and they have very actively participated without keeping anything in reserve, and have imparted the knowledge to, up-to-date knowledge. So, Dr. Keswani, I'm very thankful to you.
Thank you.
And today I'm
madam, for your nice
I'm very happy that Dr. Jumani,
yes,
I was his teacher in medicine. So I'm very
Yes,
happy
ma'am.
that he is here today. So it's good. So I'm very happy that both the courses are going on very well. Even other two courses are doing very well. Now the participants can ask the questions to Dr. Minal, but I wanted to emphasize one more thing to the participants, that initially the number was something like 55, 56, but the moment Minal put it on YouTube, the number is dwindling. So if there is an active participation, that is most welcome. Thank you, Minal. Thank you, Dr. Keswani. I'll be attending the second part also.
There are good comments on the chat box. One is from Dr. Padma Shri, other is from the Budayan Das Munshi, and they all have congratulated Dr. Minal. And this was really a nice lecture and has cleared so many things about the hyperthyroidism to our mind. And now we can move for the second session of the today, that is for the male hypogonadism. We have already gone through the classification, etiology, pathogenesis, and so many diagnoses. And all patients which come to us, they always ask two things. Doctor, I will be normal sexually, I will be able to perform my sexual life well, and other is what will be for my infertility. I will be able to produce children or not? For this, we have again two very renowned speakers for it. One is Dr. Deepak Jumani, who is the Professor of Sexology at GS Medical College and KEM Hospital, Mumbai. And I am seeing that every national conference is not complete unless we hear from the Dr. Jumani on various aspects of the hormone therapy and for various sexual dysfunctions. He's a renowned speaker, and I invite him for giving a talk to complete this session for how to improve sexual functions. So, Dr. Jumani, you are most welcome, and you are requested to start your talk.
Am I audible, sir?
Yes, audible.
At the outset, I thank Dr. Keswani, Dr. Minal, Ma'am, Dr. Alka Deshpande for giving me an opportunity to share my view. And this is a talk I really enjoy giving it because it deals with so many myths and misconceptions about the testosterone. And really, we all know the word hypogonadism itself is so obvious, which means the gonads become either less in volume anatomically or less in function also. So we need to understand any organ which gets reduced in the volume or the anatomical appearance and the functions, there's going to be some effect of that. With pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Prakash Kothari, and Sashank Joshi, I beseech them to. Mitro, our Prime Minister gave us GST. Look at his hands are down, you know. He was so sad with GST, but he had no option. Then he said, Deepak, I also told him, I offer my GST and my GST to all of you. Look, my hands are up. It's great sex therapy. Why do newborn babies have erections? Why do people fall in love and crush? Why do men have extramarital affairs? Why do sex lives become boring and tedious in the middle age? How does sexual inadequacies in 40s and 50s play havoc with our confidence and emotions? Why do old men still have sex on their minds? Now, these are some questions, but we didn't have any answers. But today, with the advances in the neurosciences, neuroimaging, neuropharmacology, we can know exactly what is happening in our body when these things happen. So the amalgamation of love and lust is basically due to chemical warfare. We call it chemical locha in the brain. So it's chemical warfare. Now, frustrate us, the love we give and take, the bond we make and the hearts we break, the mysteries of attraction, the differences that delight and infuriate us, the agonies and ecstasies of intimacies, the mating dance, sex appeal, arousal, excitement, sex drive, orgasm, and ejaculations. All these is controlled by ever-changing levels and interactions of chemicals in our bodies called hormones, peptides, and neurotransmitters. Now, this chemical cocktail hormones of neurotransmitters are various. Testosterone is the main hormone, estrogen, progesterone, oxytocin, serotonin, vasopressin, prolactin, thyroid, dopamine, DHES, pheromones, and phenylethylamine. When we look at Masters and Johnson, when we look at Masters and Johnson's male sexual response, it begins with the desire, which is definitely, we all know, due to hormones, leads to arousal, which is erection, leads to orgasm, ejaculation, and resolution. And the hormone of desire is the testosterone. In females also, there is desire, arousal, there's a plateau, and there are multiple orgasms. Women are multi-orgasmic and men are mono-orgasmic. When we look at the history or when we try to diagnose, these are the four cardinal questions we ask: that do you have a desire to have sex? Yes or no, less or more. Erections, do you have erectile dysfunction? Are you able to penetrate? Do you have orgasm? So desire is the main thing which forms the foundation of any sexual functions either in a male or a female. The health of man, as indicated by rates of premature mortality and many important measures of morbidity is poorer than that of a woman. To understand this discrepancy, there is much academic research which is going on, which link poor health outcomes and poor health behaviors with dominant constructions of masculinity and hegemonic masculinity. The literature argues that these dominant constructions of masculinity often encourage negative health behaviors such as dominant and aggressive behavior, risk taking, excessive alcohol consumption, and the rejection of sex self. Popular media sources such as Men's Health and lifestyle magazines have been recognized to contribute to the construction of masculinity through encouraging and displaying hegemonic ideals of masculinity. So all these reveal four key things which makes men's health an overlooked inequality. It is something that today we see youngsters going into the gym and making muscles, taking hormones, etc. So it's a forged physique, heterosexual prowess, career dominance, and the new man, which is you see in this. The focus on a man's main hormone, the big T, as the key to your performance in the gym, bedroom, or workplace. The association of testosterone with masculinity is further emphasized by the statement claiming that women prefer testosterone fueled men because they are more assertive, and women also admire the testosterone honed muscles. This is not true to some extent, but this is what is being portrayed. Now, when I think about testosterone, which is a male hormone, I think of these hills, Dosi Hills near Aravali, near Haryana, which is a very popular hill where Rishi Chavan used to stay. And on these hills, what happened? Rishi Chavan got married to Sukanya, and Rishi Chavan was very weak. He lost his eyes. So Sukanya tried to pray to God that please make him all right and all that. So two gods got very happy, and they told him what she did, that we will give you something whatever you want to ask, because the bhakti she did, that's how it was in the olden age. So she said that please make my husband, he's very old, make him very happy, make him healthy, make him sexually active, and give him his eyes back. So Rishi Chavan was gifted by this three Ashwamitras with some paste, and this paste, well, she was told to give it to her husband. And when she gave this paste to Rishi Chavan, he became all right. His eyes became better. He became so virile, so youthful, that this is now considered to be one of the best aphrodisiacs like Chavanpras, which is still being used everywhere in India and also abroad. Now, when we think of hypogonadism, it means the reduced small penis size and the testicular size. Male testosterone production, it definitely, look at the red thing which is keeping on decreasing. After the 40 years of age, it keeps on decreasing, and that develops testosterone deficiencies. Now, there are various definitions of hypogonadism. I will not go into the details of all the definitions because this has been already covered. But one thing I want you all to remember, that persistent clinical symptoms and biochemical evidence of testosterone deficiency is hypogonadism. So it should not be one report you got it, or if does not have any symptom, or just the biochemical. It should be both clinical symptoms and biochemical evidence should prove, and this should be there persistently. Now, what is primary? If the defect is somewhere in the testis, we call it primary. If the defect is in the hypothalamus or pituitary gland, we call it secondary hypogonadism. If the target tissues for testosterone, DHT, and estrol are involved, which leads to androgen receptor defect, 5-alpha reductase deficiency, or aromatase deficiency, also we see hypogonadism. But if there is normal testosterone, normal hypothalamic pituitary testicular functions, LH, FSH is normal, GnRH is also normal, even testosterone is normal, there is no hypogonadism. There are most frequently observed causes of hypogonadism are primary testicular causes, secondary hypothalamic or hypophyseal causes, functional hypogonadism, and target organ resistance. We must not forget there are certain idiopathic hypogonadotropic hypogonadism, which is a genetic disorder like Kallmann syndrome. And in this, we must ask the patient any history, that is he able to smell anything. If there is a loss of sense of smell, and if you see the signs of hypogonadism, this patients can we do karyotyping and we can find out that he's got. We have another syndrome called Prader-Willi syndrome, which is also a genetic disorder associated with mutations on genes of chromosome 15, anorexia nervosa, nervosa, isolated LH Pascalini syndrome, FSH deficiency also has been known. One very common thing which we see, parents come to us with their children and they tell us, doctor, my son's penis is very big, is he having some problem? Friends, try to understand, don't even do their testosterone levels. This testosterone levels will automatically become all right. They have nothing but constitutional delay of growth and puberty. Everything seems to be normal with them. The onset of puberty can delay to some extent up to 14 years. So please do not treat this patient. You can assess them if you want to, but there is no need wait up to 14 years. Look at the x-rays, everything will be fine, and don't try to treat this patient with testosterone. Everybody wants to feel better, that is for sure. Testosterone therapy is not for everyone, not nor is the testosterone deficiency the explanation of somebody is feeling fatigue, मेरे को ताकत नहीं है, कमजोरी है और erectile dysfunction है और इच्छा नहीं होती. It may not be only testosterone therapy which will help him, but we need to keep it in mind that this can be or may not be also. Now, what are the sexual dysfunctions? I'm focusing only my subject. I'm not going to go into the pharmacotherapy or anything, but I'll tell you what are the sexual dysfunctions which happen in males when they have got hypogonadism. See, as I told you, the organs become less. So there are small testes. There is lack of scrotal pigmentation. The penis becomes small, that is less than 8 centimeters in size. And the functions of this thing, erectile dysfunction is seen. There is loss of pubic hair, axillary hair, terminal hair growth along the midline towards the umbilicus is reduced. Infertility is very common because there is low sperm count. Hematocrit value increases. There is reduced drive and the activity, and some patients develop even depression, and also gynecomastia is seen in these patients. Now we know about Tanner staging 1 to 5. I will not go into the detail. Stage 5 is absolutely normal. Here the penis size is also big and the hair are also touching the thigh. We have a beautiful mnemonic which we studied in our MBBS days for women. Nobody elevates 2 mountains in head. Nobody means it's gland 1. No glandular tissue. Body means breast bud forms. You can see that's grade 2. Elevated means breasts are elevated. So it extends beyond the borders of the areola. And this is 2 mountains, size and elevation all increase, and final adult size you see this. Whereas if you see the hair, there is no, the another mnemonic, she's not a small cat. No hair, small means very little, scanty hair, labia pigmentations are there. Then there is coarse and very curly hair, adult like hair, and thighs not spared. This is the normal thing which you see, and that's how we remember it. Now we also use orchidometer. I call this as our stethoscope. Endocrinologist stethoscope is this orchidometer. It is nothing but a series of plastic beads of different size looped together, and many don't use it, but yes, it should be used because the beads are held alongside of the scrotum during the physical exam. We do it in JJ, and we are studying the volume of the testis along with the orchidometer and comparing it with the serum testosterone free and total. And we are doing a beautiful study. We have already got 110 patients already studied, and the results are very promising. Same as with the use of calipers, that you can do it also. So these clinical signs and symptoms, there is reduced testicular volume, infertility, decreased body hair, gynecomastia, loss of vigor, decrease in body mass and muscle strength, obesity, metabolic syndrome, insulin resistance, and type 2. These are all the things which happen. And the sexual symptoms are, there is definitely less desire and activity because there is no desire. They don't. Erectile dysfunction because they don't have enough blood flow. Fewer because of all these metabolic syndrome, obesity, etc. Fever and diminished nocturnal erections. There are certain cognitive and psycho-negative symptoms and signs like hot flushes, changes in the mood, fatigue and anger, sleep disturbance, depression, and diminished cognitive function. They try to forget very things many fast. So these are the most common signs and symptoms which we see. Now, androgen deficiency with onset after puberty, the clinical picture of hypogonadism can vary widely. Body proportions, penis size, and pitch of the voice do not change. However, the body and facial hair dwindle, and shaving need to be carried out as frequently. The chief clinical signs are decreased sexual potency, that is erectile dysfunction, loss of libido, and of course, because they are not able to have sex, there is infertility. And erectile dysfunction is always associated with male hypogonadism in patients who are hypertensive or all those who are taking a lot of antihypertensive drugs or other things. Hypogonadism is also associated with severe underlying conditions which include cardiovascular disease, diabetes, obesity and metabolic syndrome, and osteoporotic. It is also associated with pronounced disturbance on quality of life and detrimental effects on multiple organ systems, including reduced general well-being, depression, diminished physical strength, and sexual dysfunctions. When you look at male hypogonadism, it could be due to various reasons, and ultimately this is a mortality which you see among studies that assess the relationship between testosterone and CHD. Approximately half found an association with hypogonadism. Levels of total or bioavailable testosterone are significantly reduced in men with congestive heart disease, and approximately 1 in 4 men with CHD in the South Yorkshire serum testosterone level within the clinically hypogonadal range. They studied with Adams questionnaire. Low serum testosterone levels are also associated is a risk of so many things like obesity, diabetes, depression, osteoporosis, sexual dysfunctions. So what should be the goal of our therapy? The goal of hormone replacement therapy in these men is to restore the hormone levels to the normal range and to alleviate symptoms suggestive of hormone deficiency. This can be accomplished in a variety of ways, although most commonly testosterone replacement therapy is employed. Restoring sexual functions like libido, well-being and behavior, maintain virilization, optimize the bone density and prevent osteoporosis, possibly normalize the growth hormone levels in elderly men, potentially affect the risk of cardiovascular disease, and restore fertility in case of hypogonadotropic hypogonadism. Now, who should not be treated? Patients who have history of breast carcinoma, prostate carcinoma, benign prostatic hyperplasia, abnormal digital rectal elevation. If you see elevated levels of PSA, age there is no limit. Possibly older than 80 years, you should not try. Psychopathology, if he has any, if he's got any psychotic disorder, if he's suffering from sleep apnea, or if he's got hematocrit more than 50 or hypocoagulable state or polycythemia, you should. Now, replacement, what will it do? How will it help? When you replace testosterone in these hypogonadal men, it will improve his libido, it will improve his erectile functions, it will reduce his body fat, it will increase his bone and muscle mass, it will improve his sugars, lipids, improve his insulin resistance, it will correct his anemia, improve his bone density parameters, and also improve in depression and cognitive defects. Reduced sex drive will be restored if the testosterone levels come to normal. Fatigue will increase to enhanced energy. Depression will give him a feeling of well-being. Increased fat will become reduced fat, increased muscle. Erectile disorder will become a normal correctile disorder. There are certain interactions with testosterone which we need to understand, like warfarin, many of the OHS, insulin, propranolol, imipramine, any corticosteroid or some herbal products. For hypogonadism caused by testicular failure, male hormone replacement is often used. Testosterone replacement therapy can restore all the sexual functions and improve the muscle strength and also prevent bone loss. In addition, men receiving this therapy often experience an increase in energy, sex drive, and sense of well-being. But I strongly don't advise this to be taken by younger people who have got normal testosterone. They take it just because they want to increase the bulk of the muscle, and they ultimately land up with either oligospermia or azoospermia. So the aim of treatment with testosterone for improvement of sexual is that serum testosterone generally between 280 and 800 should be there, and dihydroestradiol and estradiol levels should become normal. They would allow optimal virilization and normal sexual functions. In late teenage male patients with delayed puberty, testicular size should always be monitored for evidence of onset of puberty. This is a very important thing because many parents are very much worried when they see their patients having smaller penis. Gonadal stimulation in patients who got hypogonadotropic hypogonadism. This therapy is only for these patients. It is used to induce puberty in boys, treat androgen deficiency in hypogonadism. It is to initiate and maintain spermatogenesis in these patients who want fertility. How? HCG binds to Leydig cells LH receptors and stimulates the production of testosterone. Peripubertal boys with hypo and delayed puberty can be treated with HCG instead of testosterone to induce pubertal development. The initial regime of HCG is usually 1000 to 2000 international units administered intramuscularly 2 to 3 times a week. The clinical response is monitored and the testosterone levels are measured every 2 to 3 months. The advantage of HCG over testosterone is the stimulation of testicular growth is seen. There is greater stability of testosterone levels and fewer fluctuations in the hypogonadal symptoms. Just giving testosterone, we are tackling the local thing. But if you give HCG, you are trying to do much better, stimulating enough intratesticular testosterone to allow the initiation of spermatogenesis. The disadvantage is they need more frequently to be given and the cost is very high. Gonadotropin therapy with the male patients with the onset of hypogonadotropic hypogonadism before completion of pubertal development may have testes generally smaller than 5 ml. These patients usually require therapy with both HCG and human menopausal HMG is definitely required to induce spermatogenesis because fertility is going to be a big problem for them. Therapy with HCGs is generally began with this. It may take 2 to 3 months. When normal levels are achieved, examination should be conducted monthly to determine whether the testicular growth has occurred. Sperm counts should always be assessed monthly during 1 year period. In general, the response to HCG can be predicted on the basis of initial testicular volume. If spermatogenesis has not been initiated by the end of 12 months, the therapy with HCG or LH administration of an FSH containing preparation is initiated in the dose of 75 international unit intramuscularly 3 times a week along with the HCG injections. So in patients with an otherwise intact pituitary gland and hypogonadotropic synthetic GnRH can be given in a pulsatile fashion subcutaneous through a pump every 2 hours. GnRH therapy is monitored by measuring LS, FSH and testosterone levels every 2 weeks. In most patients, these effects may take around 3 to 15 months to achieve sperm production. As with gonadotropin therapy, fertility can be achieved with very low sperm count. Often they go in for ICSI and other things. Once they have even 500 to 1000 sperms, they go for it, even 1 million sperms. GnRH may be more effective than gonadotropin stimulation, increasing the size of the testes and initiating spermatogenesis in many patients with hypogonadism. Now, there are 7 reasons that are very, very common why normally in every person we see that testosterone levels get low. First is A, which is found in the plastic bottles. Is a toxic thing which reduces the testosterone and converts it into estrogen. Second is being overweight. Adipose tissues contain aromatase, which converts testosterone into estrogen, which we all know about it. Even diabetes reduce the testosterone levels. Reduce sleep. All doctors are sleep deprived, so they also should take care of their testosterone levels. Because if you sleep less, your cortisol level increases. Morning testosterone levels become low on the second half of the night, which is more important. When you really need morning erections, you don't get it because you're not sleeping well. Consuming lot of soya products also reduces. Low fat diet. Zinc is very important for testosterone. Vitamin E and C is important for formation of zinc in the body. So these micronutrients and vitamins are very, very important factors. Increased cortisol level increases gonadotropin inhibiting hormone, which inhibits the formation of FSH, LH and also reduces the testosterone level. Alcohol consumption. Hops in beer very commonly is now proven to be estrogenic, and patients who do not have sex or are remaining sexless, their testosterone also reduces. There are 10 ways naturally to increase your testosterone. Avoid the use of plastics, drinks from glass or stainless steel. Avoid eating soy products. Limit the consumption of alcohol or beer or vodka. Sleep in the dark room with at least 8 hours per night. Reduce stress through relaxation. Lose weight. Increase zinc consumption. Increase consumption of healthy fats. Have a healthy sexual life. Many cosmetics are known to be endocrine disruptors. I have seen actresses coming to me with their children 5 years, 6 years with thick glasses. It is all because they were using so much cosmetics which entered through the placenta into the retina of their children's eye at birth itself. So they've developed a lot of refractory errors. This is what we see. So what is the benefit of testosterone replacement therapy with sexual dysfunctions like erectile dysfunction or rigidity? See, testosterone also helps in maintaining the composition of tunica albuginea of the penis. That is also very much important, because if the tunica is healthy and the smooth muscles are healthy, the blood flow becomes better and the erection and the rigidity is seen. This is what happens when testosterone is reduced in their body. So dramatic improvement of penile venous leakage. Venous leakage is one of the very common cause of erectile dysfunction. That means there is a flow of blood, but because the veins leak, there is detumescence very soon. The main effect of testosterone was long time assumed to be on the sexual interest and indirectly on erectile functions. Now there are newer insights which demonstrate that testosterone deficiency impairs the anatomical, ultrastructural, biological, and physiological functional substrate of penile erections, which can be at least in part restored by normalization of plasma tests. This is a report. There was a 56-year-old man suffering from diabetes who had complaints of severe erectile because of venous leakage, confirmed by pharmacokinetics. He was also having testosterone. Upon testosterone administration, his erectile functions improved dramatically. Repeated cavernosography no longer showed any venous leakage. So we have a report, and there are other studies also done. This was in 2006. There's another study done in 2018 where they show definitely there is an improvement in the venous leakage on administration of testosterone if testosterone is deficient in that person. Then a recently published multi-central randomized placebo-controlled study evaluated the safety and efficacy of testosterone gel plus sildenafil. Now, PDE5 inhibitors are the main pharmacotherapy for erectile dysfunctions. So this not only helped, along with testosterone and sildenafil, screening yielded a prevalence of hypogonadism in ED patients who failed. These patients who did not respond to sildenafil, and when they were given testosterone along with sildenafil, testosterone therapy with testosterone gel significantly improved erectile functions in response to sildenafil alone. In addition, they improved not only the erections but the orgasmic functions and the satisfaction. So combined testosterone and vardenafil treatment for restoring erectile functions in hypogonadal patients who failed to respond only to test. There was patients who failed to respond only with PDE5 inhibitors. Now here patients who were failed to respond only to testosterone were also studied. So a combination of PDE5 inhibitors and testosterone will definitely restore the sexual functions of a patient, provided the testosterone is biochemically low. This is what we need to remember. We should not put patients on testosterone unnecessarily. The evolving role, there is an increasing evidence that combination therapy is effective in treating symptoms of erectile dysfunction in patients for whom treatment failed with testosterone or just with PDE5 inhibitors alone. Testosterone replacement therapy has potentially evolved from a monotherapy for ED in cases of low testosterone to a combination therapy with PDE5 inhibitors. Screening for hypogonadism may be useful in men with ED who fail to respond prior to PDE5 inhibitors. So this is very important, especially in diabetics or other metabolic syndrome. There are common misconceptions that testosterone replacement therapy may accelerate the rate of development of prostate hyperplasia. LUTS may become worse, lower urinary tract symptoms may become worse, or these patients may get cancer of prostate. So in contrast to date, 3 year safety study of using testosterone gel, which is the safest way to give the simple, Intas company has come out with Androtaz. It's a very transparent gel. Just take it and apply it on any part of your body where there is no hair. You will find there was no change in the prostatic disease or digital rectal examination or uroflow and or obstructive fluid symptom. One patient had to be discontinued after 400 patients whom they studied. CA prostate is definitely an absolute contraindication of testosterone replacement therapy. Post radical prostatectomy hypogonadal men may be given if the PSA is less than 0.1. Reasonable period for elapse between last treatment has been done and symptomatic hypogonadal state is there. So we need to understand testosterone does not become zero in all patients. It gradually keeps on reducing. There is some testosterone left, but enough studies that there have been association of cancer of prostate with testosterone, but it is not that testosterone induces cancer cells in the test. It is not proven as yet. Yes, there has been association which has been seen. So my take home message is that you need to have a recommended protocol. You need to take a detailed history to exclude symptomatic BPH, examine digital rectal examination to exclude. These two are absolute contraindications. Investigate PSA free and total, sonography of kidney, urinary bladder, follow up with digital rectal examination, PSA after 3, 6, 9 months, and yearly urological consultations if high PSA. Well, check for any drug interactions. When you're giving testosterone, please check for if he's on warfarin or if he's on hepatotoxic drugs, if he's on insulin secretagogues, antivirals, antibiotics. These all things we need to check when we are. Now, one nutraceutical called fenugreek glycoside in a saponized form. Fenugreek is nothing but methi. Just by 8 weeks of treatment, the levels of free testosterone was found to have a 98.7% increase from baseline 17 to 35 in fenugreek FG group, whereas placebo group showed moderate increase from 21 to 37. The testosterone baseline is significant and very, very important. So we need, this is our Indian study, and this we need to understand when we have patients of diabetics, all of whom are having hypogonadism. If we give them fenugreek, which is a natural nutraceutical, which also reduces their blood sugar, also increases the free testosterone. We have contraindications in certain patients to give testosterone, or they are also worried. So we can give them this nutraceutical, which increases the free testosterone and the desire. So by taking fenugreek, his desire becomes normal. The first foundation of a male sexual response becomes normal. And then by giving them small dose of PD5 inhibitors, they can still have very good erections. Or we can also give them L-arginine, which will produce nitric oxide, which also reduces as we age. So nitric oxide, as we know, is the initiator of the whole erectogenic mechanism. Nitric oxide will stimulate the CGMP pathways and can produce relaxation, release of nitric oxide. All those things can happen naturally, and we can give our patients a very good sex life by just giving them good nutraceuticals. So the initial assessment of all men with erectile dysfunction or diminished libido, which are the sexual dysfunctions, can be determined with serum testosterone. Men with ED or diminished libido, documented testosterone deficiency, are candidates for therapy. Please, friends, just don't go only by the biochemical report. Laboratories are very notorious. You may not have a correct report from one lab. You need to do it from 2-3 labs, but it becomes very expensive. If he's got symptoms and if he's got biochemical evidence, then only start. There is evidence suggestive of therapeutic synergism with combined use of testosterone and PD5 inhibitors, which we have got studies to know. And in patients who have got metabolic syndrome, testosterone replacement therapy definitely helps, because we have got beautiful study by my friend Paresh Dandona from Buffalo. He gave patients 2 years treatment of testosterone therapy in diabetic with hypogonadism. These patients not only improved in their glycemic control and insulin resistance, but also had improvement in their symptoms of hypogonadism, resulted in normal serum testosterone, improved glycemia, endothelial lipids, insulin, quelled the symptoms of hypogonadism. Potentially, they reduce the risk of cardiovascular diseases in these obese patients with family history and with this thing and type 2 diabetes. So, and what is another thing which we need to advise is lifestyle model. You may be Hindu, Muslim, Sikh, whatever, but make lifestyle as your first religion. Because what lifestyle does is, please remember, we all are in a pro-inflammatory stage after the age of 40. We are more prone to all sort of things because our body is in a pro-inflammatory state. If you have a healthy lifestyle, I don't have to explain what is lifestyle modification. We all know about it. If you adopt that lifestyle continuously, you reduce your pro-inflammatory milieu in your body, you reduce the insulin resistance, you reduce the oxidative stress, you also reduce the endothelial dysfunction. And if all these things you are doing it, you have improved well-being and reduced burden of sexual dysfunctions. So along with the hormone therapy, whatever you give, lifestyle modification and counseling should be the first thing which you start with. Then you can go in for pharmacotherapy, because two-time Nobel Prize winner Dr. Linus Pauling declared nearly all diseases can be traced to a nutritional deficiency. When he was receiving his second Nobel Prize, he told on air that every disease can be due to nutritional deficiency. So when we have such brilliant people giving us beautiful wisdom, why shouldn't we adopt to our patients? Diabetes reversal or remission is not a myth. Hypertension, it is up to us. We can bring it down. Dyslipidemia, obesity, we have bariatric surgery, reducing of smoking, cutting down on smoking, alcohol and other substances of people. It's all possible for us. How much time we give to our patient, how good we are at counseling them. So all these things is very important. Food isn't like medicine, friends. Food is medicine. So take care of a food which could be very good for you. Take quality food, what is required. My last slide. Hypogonadism is definitely really a clinical and biochemical syndrome. Don't just treat only clinical or only biochemical things. Low desire and erectile dysfunction are common in these patients with hypogonadism. Delayed puberty should not be treated with testosterone replacement therapy. Testosterone replacement therapy with caution and monitoring is the key. You have to monitor PSA, testicular volume, etc. Free total testo, SHBG, FSH, LH, PSA have to be tested in any patients who come with symptoms of erectile dysfunction, low desire, reduced volume of the testes, reduced penis size, etc. Don't start triage in patients having cancer of prostate or breast, raised hematocrit, LUTS, the lower urinary tract symptom, or patients who are already into failure or who have untreated obstructive sleep apnea. Counseling on realistic expectation. If he is a man of 70 or 60 coming to you, please tell him that you will not be able to perform like how you were performing when you were 30 or 40 or 20. So this realistic expectation ka counseling we need to do to our, along with the nutritional counseling, along with the lifestyle modification. If you do all these, friends, trust me, erectile dysfunction is a correctile dysfunction. If so, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions.
Thank you, Dr. Jumani, for your nice talk and making us so wiser that not only testosterone is to be given, so many new things you told about 10 things to not to use plastic and take so many other things. And of course, fenugreek. And this all was very informative. And this was, I think this will be useful to all the audience and participants. And thank you very much, Dr. Jumani, for giving this nice lecture. Now we move for our second talk of this session. And for this, we have another brilliant andrologist. He is MCH Urology and professor and head of the Department of Urology of our SMS Medical College. He is a renowned andrologist also at the same time. And both of these speakers were busy in some andrology conference in Delhi. And from there only they are able to give lecture to us. And we are thankful to both of them to sparing time in between the conference. Dr. Shivam Priyadarshi, HOD Urology from SMS Medical College, will be deliberating a lecture on how we can improve the fertility in patients of hypogonadotropic hypogonadism. Dr. Shivam Priyadarshi, you please start with the lecture.
A very good afternoon to all of you. At the outset, let me thank the organizers, the Association of Physicians of India, API, and particularly Dr. Prakash Keshwani for giving us this opportunity. And I'm very thankful to Dr. Deepak Jumani that he has done my full job. So he has almost done with case of hypogonadotrophic hypogonadism. So I will just try to simplify the whole thing as much as possible and do it in a brief and simple manner. So hypogonadotrophic hypogonadism, we all know male hypogonadism could be due to 3 reasons. One is problem is at the testis level, when this is called a primary hypogonadism. When the problem is at hypothalamus and pituitary gland, it is secondary hypogonadism. And when the problem is at the target organ, there is a problem of androgen receptors or androgen insensitivity, then this is probably due to the receptor defect of or the enzyme deficiency. So now we are dealing with hypogonadotrophic hypogonadism, where there is a secondary to low level of gonadotropins, the testosterone level goes down. This is called secondary hypogonadism. It is important to understand here that primary hypogonadism is not equal to congenital, or secondary hypogonadism is not equal to acquired, which we usually in our terminology think. So primary hypogonadism is actually the defect primary lying in the testis, whereas secondary hypogonadism is the defect lying in hypothalamus or pituitary gland. And male hypogonadotrophic hypogonadism is probably one of the most important causes which is amenable to medical therapy in male infertility. So it's a very important part of evaluation of male infertility. So the causes could be many. It could be idiopathic, it could be genetic cause, it could be acquired, and also could be functional causes. So it is usually divided into either congenital or acquired, or it could be also called as prepubertal or postpubertal. So amongst the congenital causes, we have idiopathic hypogonadotrophic hypogonadism, hereditary hypopituitarism, Kallmann syndrome, Prader-Willi syndrome, and there are other syndromes which can also cause the same problem. One of the common important cause which is related to hypothalamus is the Kallmann syndrome, where there is X-linked disorder and there's a mutation of CAL1 gene which encodes for the neural crest adhesion cells, and there is a inability of the GnRH secreting cells to migrate from the olfactory placode to the olfactory bulb and hypothalamus. So the presentation is very typical. Many of these patients will present with micropenis, cryptorchidism, and the MRI will show the absence or hypoplastic olfactory bulb. So this is a typical presentation. And the patient may also present with sometimes, besides anosmia, unilateral renal agenesis, or midline defects like cleft lip, and they may have color blindness or hearing loss also. Amongst the acquired causes, we can have tumors of the pituitary gland. There may be head injury leading to tremors to the pituitary. There may be drugs which can induce this hypogonadotrophic hypogonadism, then the infiltrative disease. And there are many other functional causes of hypogonadism, particularly like obesity, excessive exercise, anorexia, hypothyroidism, chronic medical diseases. All these can cause functional hypogonadism. So when we take history of these patients, the symptoms would depend upon the age of their presentation. So many of these children who present, they may not be recognized because unless they have other hormonal problems like growth retardation or other endocrine abnormalities. And many of these children and boys might present with micropenis or cryptorchidism. But most of them usually present because of delayed puberty. And in adolescent, they will have kind of, besides cognitive impairment, poor muscle development, they will have a small testis, decreased phallus size, a scanty pubic and axillary hairs, and unicoid presentation, gynecomastia, high-pitched voice, all features of hypogonadism. And sometimes they will present in adulthood, like in post-pubertal causes of hypogonadism, where they may present with decreased libido, decreased muscle mass, impotence, infertility, all these kind of symptoms. So the basic difference between pubertal and post-pubertal hypogonadotrophic hypogonadism would be that the prepubertal would usually present with poorly developed secondary sexual characters, with small gonads, small penis, unicoidal stature, lack of development of the scrotum, and small prostate, loss of hairs, and then sexual problems like lack of libido and infertility. Whereas the post-pubertal usually presents with normal stature, will have normal sexual development otherwise, but they may have gynecomastia, some thinning of hairs, and they will present with infertility or the sexual dysfunction problem like loss of libido, or sometimes loss of other non-specific symptoms like loss of energy, loss of muscle mass, etc. So these are some facts about spermatogenesis, how it happens. The testicular growth is typical of early puberty, which seems to be the consequence of seminiferous tubules, Sertoli cell proliferation in response to the prepubertal rise in serum FSH level. And men with congenital hypogonadotrophic hypogonadism usually lack this both mini-pubertal, which occurs at 1 or 2 years of age, and then the pubertal periods of this proliferation, and present with the prepubertal testis, which is a very low volume testis. And they will have lower inhibin B serum levels, and that is evident by histologically also. So these patients would be investigated. They need to be done, hormonal assay needs to be done in the form of serum testosterone, FSH, LH, estradiol, and sometimes prolactin, TSH, and cortisol level also. We need to distinguish, because most of these patients need to be differentiated from delayed puberty due to CGDP, that is congenital delayed growth and puberty. So that has to be differentiated from a pure organic form of hypogonadotrophic hypogonadism. And this could be done by different stimulation tests like GnRH challenge test, SCG challenge test. So the diagnosis is basically, if in a case of hypogonadotrophic hypogonadism, you have a low testosterone level along with low gonadotropins. And patients who have a kind of post-pubertal hypogonadism or a functional hypogonadism, they will have low testosterone along with a low normal LH rather than a very low LH. So these patients may present differently. Like suppose if a boy presents at the age of 14 or 15 years with a delayed puberty, now here the key issue would be to differentiate it from CDGP, that is constitutional delay of growth and puberty. And if the pubertal development goes beyond 18 years old, then the key issue would be because then we can exclude CDGP, and then we have to treat these patients for androgenization. And the third kind of presentation would be an adult patient who is a married man with normal puberty presenting with infertility. So that would be a post-pubertal hypogonadotrophic hypogonadism. So when a patient of 15-year-old boy presents with a delayed puberty, then delayed puberty would be defined as when the puberty is not gained by girls at the age of 13 and boys at the age of 14. This standard stage already has been described by Dr. Jumani, which is to know exactly how the external genitalia develops. So managing a case of delayed puberty. So if the boy is a 15-year-old, we need to distinguish between either this is a hypergonadotrophic or hypogonadotrophic hypogonadism. And then we do a hormonal assay, and that will tell us whether this is hypogonadotrophic or hypergonadotrophic. So if the patient is having low testosterone with high LHFH, this is a case of primary testicular failure, we need to look for the etiology, and this patient will require a lifelong testosterone replacement therapy. Whereas if a boy is coming with delayed puberty with low LH and FSH, this is a typical case of hypogonadotrophic hypogonadism. And here we need to distinguish it with the constitutional delay and the various stimulation tests that have been described. Actually, none of these tests are unequivocally correct to distinguish between the two conditions. So there is a presumptive diagnosis of constitutional delay if the patient gives a family history of delayed onset in the family, or if the height is less than 5 percentile, but normal for bone age, and there is a post-pubertal development which is normal. So this has already been dealt. So usually these patients, we would not start any kind of treatment. If the patient is too anxious, we might start a low dose of testosterone injection in them, maybe 50 to 100 milligram per month for 3 to 6 months. And then this dose will advance puberty without impairing the height potential of these children. And we need to watch for 3 to 6 months for a spontaneous onset of puberty. If no puberty occurs till the age of 18, then definitely it rules out constitutional delay, and then we need to start TRT therapy in this patient. So a patient who is an 18-year-old boy presenting still with a delayed puberty, here we have ruled out constitutional delay, and so we need to treat this patient. And the main issue would be androgenization, because this is still an unmarried young male, and we need to replace testosterone either by directly testosterone therapy or by gonadotropins or even by GnRH therapy. So GnRH therapy is can be given as a pulsatile GnRH, which is a portable infusion pump, but these pumps are quite inconvenient and difficult to maintain and not available everywhere. So most of the time, this therapy is not practically possible. So these patients usually would traditionally require testosterone for androgenization. And if they desire pregnancy, then gonadotropins. So how do you give testosterone in these patients? So we start testosterone with 100 milligram once a month for 3 months, followed by 100 milligram once a month into 3 months, twice a month for 3 months. So slowly increasing the dose to 250 milligrams twice a month for 12 months. So, and for long term, you will give 250 milligram once every 3 weeks. So if the person is desirous of fertility, then definitely we have to stop TRT, and this patient will require gonadotropins, that is LH and FSH. And here the patient counseling is very important, because the treatment may require at least 1 to 3 years, and the cost of SCG and FSH in the injection may be quite high. That is, the whole treatment might cost 2 to 3 lakhs of rupees. And still the natural pregnancy rate would be around 50%. And still many of these patients may require assisted reproductive technique. And so all this, after this counseling, if the patient opts for gonadotropin therapy, we should go ahead. Otherwise, the patient might opt for even donor insemination in these cases. So the principle behind gonadotropin therapy for fertility is that we need to achieve initial testicular growth and then add FSH to complete the spermatogenesis. And we expect a count of around 5 to 10 million per ml. Though it appears to be low and below normal, but at 5 to 10 million, it seems that most of the patients who are going to be fertile will actually achieve pregnancy with this particular quantity or count of sperms. So continue this till pregnancy is achieved, and then maintain the LH if second pregnancy is desired. And once the family is complete, you finally switch to lifelong TRT. So LH replacement for fertility is given at HCG injection. So the dose options we have is 5,000 units per week, 2,000 units 2 to 3 times a week, or 5,000 units twice a week. So because many of these patients would require in different doses. And we must understand that least number of injections would mean greater convenience to the patient. So the treatment protocol will be, we need to stop the testosterone level, start SCG injection 5,000 units every week, deep intramuscular for 3 months. and we need to assay the testosterone level at 3 and 7 days after the last injection. The third day assay will tell us whether the testis is responding to SCG or not. And the 7th day assay will tell us whether the SCG effect is sustained for 1 week or not. And then we need to monitor the testicular volume and androgenization. So we need to titrate the SCG dose. So if the patient has inadequate response on both 3rd and 7th day, that means he requires a higher dose. So we need to increase the dose to 5,000 units twice a week. And if the patient has a good testosterone level at the 3rd day, but low at 7th day, that means the response is adequate, but it is not sustained. That means he would require divided doses, rather 2 or 3 times a week, rather than a once a week dose. So you might give 2,000 units twice weekly. And if both D3 and D7 are increased, that means the response is adequate, and we need to continue with the same dose, that is 5,000 units weekly. So when we are giving SCG in these patients, we need to monitor these patients 3 monthly for testicular volume, for his libido and erections, for the androgenizations, and for testicular levels just prior to the next SCG injection. And we need to adjust the dose if there is inadequate response. So what do you expect out of this SCG therapy? So we expect that the testosterone level will be in the mid-normal range with our therapy, and the testis volume would increase by 2 cc every 3 months. So testis volume should be around 12 to 14 mLs at 12 to 18 months of treatment. And we expect the androgenization to happen and the appearance of ejaculate, which usually occurs by 6 months of treatment, with progressive increase in the volume of the semen. But still, it may remain azoospermic, though the volume increases. So here, now we have to start FSH in the form of HMG or a recombinant FSH. We need to add FSH to complete the spermatogenesis when the testicular volume reaches an optimum size, that's 10 to 12 mm. And then again, the dose options for FSH would be 37.5 units thrice a week, 75 units thrice a week, or 150 units thrice a week, and sometimes even only 75 units daily. So the common doses would be 75 units thrice a week. We usually combine SCG and FSH together, 2,000 plus 75 units of FSH. So HMG can be given, or both, or recombinant FSH can be given, both together, and can be mixed in the same solvent also. So these are the ways in which they can be combined. And then we need to monitor the semen and testis volume every month. So we expect the sperm to appear at around 6 to 9 months of age, and they should progressively increase over the 6 to 12 months. The patient usually remains oligoasthenospermic with counts of around 5 to 10 million per ml average. But again, these men are fertile with this low count also. So if the count remains even poorer, then we need to increase the dose and give HMG even daily. And in the meantime, we need to ensure that the wife is optimally fertile. And if the pregnancy doesn't happen within 12 to 18 or 24 months, then we might think of doing an assisted reproductive technique in this patient. Once the pregnancy is achieved, we need to cryopreserve the semen sample, and then we can continue with SCG alone. Will maintain the moderate spermatogenesis and will allow for quick improvement if there is abortion. And then we can continue it till our second pregnancy. So once the family is complete, then we can stop gonadotropins and then switch over to testosterone replacement therapy in these patients. Patients who have prepubertal hypogonadism, traditional therapy, again, as I said, would be testosterone for androgenization and gonadotropins for fertility. So can we use gonadotropins instead of testosterone to achieve androgenization in such a person? Yes. The advantages of LH or the SCG over testosterone would be that it is more physiological, more regulated levels of testosterone are there. Testis size will also increase. There is early restoration of fertility when desired. And SCG is still not very expensive in India. So again, this is a very viable treatment option for even androgenization. So the dose usually is 5,000 units every week for 3 months. And then again, the same thing, we assess the T levels at D3 and D7, and androgenic response is measured. So if inadequate, then we would switch to testosterone. Otherwise, we might continue with SCG injection. The third type of presentation is patients who present post-pubertal hypogonadotrophic hypogonadism as infertility in a married man with normal puberty development. And this is a case of typical acquired hypogonadotrophic hypogonadism. And we definitely should look for the different causes of hypothalamo-pituitary failure before starting the treatment. So the acquired causes could be various anatomical causes like tumors, head injury, drug-induced, infiltrative disease, and they could be functional also because of chronic diseases, anorexia, excessive exercise, obesity, hypothyroidism, and hyperprolactinemia. So in patients of post-pubertal hypogonadotrophic hypogonadism, for restoring fertility, we would start both SCG and HMG together. And this is usually given thrice a week. And we expect the sperm to appear in the semen within 3 to 6 months. And normal semen analysis can be achieved rapidly in such patients, and natural pregnancy is also likely to happen if the wife is definitely normal. So we need to follow up these patients every 6 weeks, and the clinical examination needs to be done for virilization, appearance of facial hair, the voice, and the Tanner staging. And the testicular volume can be assessed by Prader or Oxidometer or by ultrasound. And we need to document the various side effects like acne, gynecomastia, and allergic reaction. And serum testosterone level should be measured till it achieves the normal level. We might also measure the serum inhibin B level, AMH, estradiol, hematocrit, liver function test at 3, 6, and 12 months, and semen every 3 months. So to conclude, gonadotropin therapy is in the form of SCG alone or combined with HMG or FSH is indicated to restore spermatogenesis in hypogonadotrophic hypogonadism men wishing to father a child. Androgen replacement therapy should not be used for the treatment of hypogonadotrophic hypogonadal men who desire fertility. And because of the cost, gonadotropin treatment for fertility restoration can be used until the pregnancy is achieved, followed by testosterone replacement therapy, which is rather cheap. And assisted reproductive techniques can also be used for couples who are unable to attain an unassisted pregnancy even after this kind of therapy. In up to 10% of cases, the patient exhibits a sustained sperm response even after stopping the SCG therapy. So these patients may not require any kind of treatment. So adequate serum testosterone levels, even after complete withdrawal of medication, can happen in this minority of patients. Thank you. Thank you very much.
Thank you, Dr. Shivam. It was a nice presentation that how our patients with hypogonadism who are very desiring for the issues can be helped while giving this gonadotropin therapy. What do you think, Dr. Shivam? How many of the patients who go for this gonadotropin therapy, how much percentage have enough spermatogenesis for having a child?
If we follow them properly and give an adequate treatment in an optimum manner, then the response could be around between 60 to 80%. So the patients may have around a count of 5 to 10 million in almost these patients. But again, the pregnancy rate could be between 30 to 50%.
Okay. And at the time of adolescence or around 18 years, we should start with the HCG instead of testosterone if he can afford, right?
Right.
So he will have a better outcome in pregnancy. This was given message by the Dr. Jumani also and by you also.
Thank you. Yes.
So it is better to start with the HCG for androgenization. Later on for the spermatogenesis, we have to add FSH.
Right. So if SCG gives a good response, definitely SCG needs to be continued. If SCG is not giving as good a response as testosterone therapy, then we might have to start TRT for at least androgenization and later follow it with gonadotropies for fertility.
Thank you. Thank you very much. Dr. Jumani, being even endocrinologist, we used to treat the patients with the hypogonadism with the testosterone supplement. We do not usually think of other disease modifying or lifestyle modifications. And again, sildenafil, you told that can be having a adjuvant effect and symbiotic effect and can increase the performance and improve the sexual dysfunctions. So shall we give all the patients, or first we start with the testosterone and then we should think of this? Because many of the patients with the hypogonadism, when we give androgens, still they always complain that they do not perform well or there is some deficiency.
Please understand, the male sexual response begins with the desire, leads to arousal or erection. So the first he needs is desire, and desire is definitely due to less testosterone. You have to give him testosterone to bring it at a certain level, and also supplement PD5 inhibitors along with it. Studies have shown that you just give testosterone, they don't improve. You just give PD5, they don't improve. But if you combine both, there is definitely a result, because you're taking care of the desire and the erection part of it. So they have beautiful results.
Yes. And many of our patients with hypogonadism have some element of depression also.
Everybody will have some depression, because any man who even has an early ejaculation once, or even if he has erectile dysfunction even once, he will feel that his manhood is hit on his head, so he will definitely, there is always some psychological component with that. Hence we need to counsel them very well. We should make them aware that you are not the only one. This can happen to all patients, but there is a treatment available where you can become better. So he should not feel that he's the only one having this. That's what the thing is.
Any role of antidepressant in addition to this counseling?
No, not at all. Antidepressant will increase his erectile dysfunction.
Okay, so the counseling will be the best for this.
Yes.
Right.
And of course, lifestyle modification is required.
What I can say that today both of the speakers have done a marvelous job. So this can help in managing the patients of hypo patients, and we can improve fertility, improve sexual functions. I am thankful to both of you, and by chance both of you are in Delhi, and how you have managed, I know it, that one was on the desk and other was on the managing.
I am sitting in the hall only where I finished my panel discussion.
I'm in a hotel. I'm in a hotel room.
Behind you, exit is written on the wall of the hall.
Yes, I'm in the hotel, just going down.
Thank you very much. Thanks a lot. To
Thank you, Prakash. Thank you very much.
When we have
welcome, ma'am.
Thank you.
Again, after some time we will have this certificate course again, and we will bother you.
Sure.
Thank you
very
much. Thank you,
Shivam.
Bye-bye.
Thank you, Dr.
Madam Alka, will you like
Keswani.
to say something?
Thank you, Dr. Keswani. It was very enlightening session, because these aspects are never covered in any medical conference or, unless you specially think and read about it. So this was a very good knowledge to all our participants, and they can look forward for a very positive response, and they can give new lease of life to these hypogonadic patients. So thank you very much, and I thank both the experts for imparting knowledge to our participants. Thank you very much.
Thank you, madam. Thanks a lot, madam. Bye-bye, Dr. Shivam. Bye-bye, Dr.